Welcome to the Heart of Healthcare podcast.
Hello, listeners, and welcome back to the Heart of Healthcare podcast. I am Steve Krause, your co-host, and I am joined today by Dr. Jennifer Schneider, who goes by Jenny. Dr. Schneider, Jenny, I Googled her. I've known her for a long time, but I looked at Google just to look at her bio, and it describes her as one of the most prominent figures in digital health. So Google's your friend, Jenny, in terms of describing your career, but I actually think it's very true. I'm really excited to talk to you today. Jenny has led several companies that have been vanguards in our space, Castlight Health, Livongo, which is probably the most successful digital health company in terms of enterprise value creation. And now she is the co-founder of her third company, which is called Homeward Health. And excited to talk about that and the Medicaid care space in general. So Jenny, welcome to the Heart of Healthcare.
Thank you, Steve. Delighted to be on this.
Yes. Well, listen, there's so much that you've done in your career, but let's start with the fact that you're a doctor by background. And, I want to talk about a doctor who becomes a CEO because that's not always a normal transition. But tell me about how did you become a doctor? Like, what was the background story there?
Yes, great question. So I grew up in Winona, Minnesota, southeast corner. I am a middle child. My dad runs the auto parts store that my grandfather started. So we do not come by healthcare as a background of a family at all. But when I was 12, I was diagnosed with type 1 diabetes. I got to meet Dr. Roger Nelson at the Mayo Clinic, who became my endocrinologist at the ripe age of 12 and became fascinated in that world. And so that is what drew me into healthcare. I went to medical school at Johns Hopkins.
Winona, Minnesota, I don't know where that is, but my sense is it's a rural part of America.
You got it. Yes.
The Mayo Clinic is like one of the most formidable, well-known medical institutions. Like, how did you get from Winona to Mayo? Like, how did that journey happen for you and your family to be able to get to this doctor who sounds like he really changed your life and is prominent endocrinologist at one of the most leading academic medical centers? Like, how did that happen for you?
Yeah, and actually the connection of growing up in rural parts of America, diagnosis of type 1 was definitely the entree into Livongo and into Homeard.
Right.
From a Homeward standpoint, Homeward is focused on care delivery in rural parts of America. When I was diagnosed, I was put in the intensive care unit in Winona Memorial Hospital, same place I was born, and was quote unquote stable, went under treatment for diabetic ketoacidosis upon diagnosis. I say quote unquote stable because on the second night, they actually let me out of the ICU to go attend my 7th grade middle school dance for a couple hours to come back.
Wow.
So that'll maybe show you a little bit of the healthcare decision making.
Sheesh.
And it wasn't until a few weeks later that I actually ever saw an endocrinologist. And I was referred into Mayo Clinic, which is about an hour and a half from my house, to get specialty access care weeks after diagnosis. And that I say that because it wasn't until I went to medical school at Hopkins and I understood that those first few weeks of after diagnosis are probably the most fragile time for anybody who lives with type 1 diabetes, because there's so much volatility, and the things that acutely harm people with type 1 diabetes are diabetic ketoacidosis and hypoglycemia and inability to tackle those. And those things happen without practice, instantaneously. And so that is the most critical period. And that actually informed a lot of the thinking that my co-founder and I, Amar, have put into Homeward and the focus on healthcare delivery in rural parts of America. That, coupled with the idea that my dad in the auto parts store, my first job was to get in a little MPE white Chevrolet stick. Used to listen to Rush Limbaugh. It was the only radio station that would come through, and deliver auto parts to a bunch of industries in rural parts of Minnesota. And so we had the ability to deliver auto parts, but for healthcare, you couldn't actually bring healthcare to the person. The person had to go to health. The person didn't have to go get the auto part. The auto part went to the industry, but healthcare was not, quote unquote, as efficient or as important as auto part delivery.
Interesting how the connections are made between your experience and what you're doing now. Hey, so 12 years old, you're diagnosed with type 1 diabetes. How did that affect you as a young kid, a young adult? Like, how did that shape you? Did that experience make you want to be in medicine right out the gate, or was this something that was an acquired taste, if you will?
Yeah, I think it impacted me a couple different ways. Number one is the ecosystem as a 12-year-old with type 1 diabetes tells you all the things you can't do. You can't go
Mm.
scuba diving. You can't run a marathon. You can't fly an airplane. So immediately, as a middle child, I said, great, I'm going to go scuba diving. I'm going to run a marathon. I'm going to learn to fly an airplane, right? I'm going to change that ecosystem. The second thing is that you learn really early on that it's a chronic condition and that it's the, hundreds of choices you make throughout the course of the day that are actually driving your blood glucose control.
Yep.
And you have to be in charge of that. When I
Mm.
would follow up with my great endocrinologist every 3 months, he would look at the piece of paper where I had written down blood glucoses and say, 4 weeks ago on Wednesday afternoon, why was your blood sugar 398? Of which I couldn't remember. And we
And
would
that
come
literally
up
back
with
in that day, you're writing it on paper, literally. You're
writing it
your
on paper. And even
Yeah.
worse, Steve, it's like the reality of actually trying to check your blood glucose, wait for 60 seconds to get the
Yeah.
reading, then write it on the same piece of paper in a format. Really what ultimately happened is I would just scribble down a bunch of numbers, made up numbers before going into the endocrinologist's office, because I also recognized whatever decision we were making off that piece of paper was fairly irrelevant because there was no context around any of it.
This is going to be a negative connotation, so please don't take it the wrong way. But does something like that make you a control freak?
I wish I were a control freak. I think a lot of people with type 1 do have control tendencies because you're asked at a very early age to really tightly control and manage
Right.
something to keep you alive. And so
Right.
that then transcends into other parts of people's lives. I fortunately and unfortunately don't have that build, but the question is actually the right question to ask. And there are a lot of people in our ecosystem that do have that and have that real quantified self. I'm a little bit more of a rather than a splitter. So I like general trends rather than specifics.
I've never heard that term, lumper than splitter. How has living with this chronic disease changed you as a person and a leader?
Well, for sure in healthcare, I think I'm far, far more empathetic because every day I run up against the, inadequacies of the healthcare system. And we all have these, and I've heard people talk about these on their show. But as someone living with type 1, the hardest thing of living with type 1 is not the condition. It's fighting the payment mechanism to get the goods that I need to actually deliver the care that I need.
Even for you?
For me. So let me give you an
Wow.
example. And I just wrote a letter to the CEO of Dexcom. So this is very relevant. And I saw that Kevin was on your podcast.
Yeah.
I know he's left recently. I know him personally, but I use a closed loop system where I'm on an insulin pump that talks to my CGM. My CGM is made out of Dexcom. I'm on the G7, the most recent up-to-date technological advancements. They're good for 10 days per sensor. That's what insurance covers. They typically last maybe between 2 to 7 days. So every month I buy them out of pocket, which is nearly $1,000 to get the sensors. I can afford to do that. That's not the way that healthcare should be delivered for individuals. But
Right.
the issue is that I was telling you, I just did an Ironman on Sunday and my CGM, I inserted it and within 1 hour it stopped working, but I had run through all of the other ones I had stockpiled, entered this one 2 days before, and I couldn't get another one, even with cash pay in time to do it. The hard part is that I'm dependent because of the insulin pump on the continuous glucose monitor.
Oh.
So it was an ecosystem failure. And I'm not alone in this world. This is
No.
when you talk to anybody living with type 1 diabetes, the equipment and the technology advancements are massive and they're beneficial when they work. And when they don't, it's very problematic.
Interesting. So med school, you have a very you're very pedigreed in terms of going to great institutions. When was that a realization for you that you want to do this?
That was, I think from the get-go, when you asked me, after my diagnosis, I was diagnosed January 12th when I was 12, 1987. And if you would have asked me by the end of that year, I would have told you I was going to be an endocrinologist. So I knew med school was in my future. And the real reason
all your friends
for that,
must have been like, Jenny, what
does that mean? What does that mean? Yeah. But I had the good fortune of finding Dr. Roger Nelson at the Mayo Clinic, who was very intelligent from a medical standpoint, but truly understood that I was a person and that was solving me as a person. And I got to understand and live with this condition. And that was so empowering as a 12-year-old that I got to take control. And that really changed the way that I thought about healthcare. We talk a lot about consumers, but the reality is we're just people. We're people. We deal with health the same way we deal with other parts of our world. And the more that you could understand the personal journey of what people really want in that's the ultimate outcome. You drive ultimate outcomes through doing that. And I saw him do that with me.
But it does feel like, I mean, to just use two terms, it does feel like he treated you as such and you internalized being more of a consumer, like an agent than a patient. Like sometimes I feel like a patient is, I mean, is someone who receives care rather than is actively involved in their care. So
Yes.
It sounds like that was something that really changed your perspective on this industry.
I think there's certain conditions, Steve, that you have to be an active participant or you don't get to pass go. And I think
fair.
type 1 diabetes is one of those. If you're not an active participant, it is truly hard to stay alive.
Yeah. I see that sometimes with folks who unfortunately are diagnosed with cancer too. The folks who really engage in understanding the science and really push the thinking of the practitioner. They're acting like consumers and agents. So med school. So I think you actually went down the path of you were chief resident, I heard, or I think I heard on a podcast. So you were going down the institutional path. You obviously went to great institutions, got promoted in great roles. Did you actually practice?
I did.
For a while?
I did.
Okay.
I did. So I went to Hopkins for med school. I did my residency at Stanford. I stayed and did a chief year at Stanford.
Okay.
And then I went into practice for a year. I actually worked in Kaiser up in Santa Rosa, which was really interesting from a system standpoint. I learned a ton. And in that journey, I learned a couple things about myself, which was I love teams. I love teaching. I love high pace intellectual challenges. And I loved people, but I didn't like the repetitive of the answer from an intellectual standpoint of being an internist. And so I went back to Stanford and got a master's in health services research under Alan Garber, who is, I think, just, super inspiring in a lot of different ways, and got to take classes in the business school to think about systems and getting things to scale on a solution standpoint. And I really enjoyed that. So, and then while I was in my master's, I met a gentleman that you know as well, Giovanni Colella, who's good friends with Dr. Garber, Dr. Colella, Dr. Garber. And so I had a chance to go join him in Castlight.
Yeah, I want to talk about Gio, and I want to talk about another entrepreneur CEO you worked with, Glenn Tolman, because they're two of the pioneers in our industry and different characters. So I want to talk about them. But let's talk about Castlight, for instance, because so much promise for that company and for price transparency as an ideal, a goal. And yet I'm not sure the promise has ever been truly realized. These are my words, not yours, so please push back. But how do you feel about that journey at Castlight and then also the pricing transparency space in general, like where we are versus you joined Castlight when? What was that year?
2009. I joined in 2009.
Okay.
Yeah.
So fast forward 15 plus years, like where do you think we are on that space?
Yeah. Well, I joined 2009 before it became Castlight. It was originally Maria Health, which is
I know. I saw the pitch. I saw the original pitch.
Yep.
Yeah.
So you've seen that.
Yep.
And I think the interesting part of the transparency, cost and quality transparency journey was that at the time we would reach out to individual people and employers, and they had no idea that if you were in network, that there was any difference between your in-network price or your in-network quality. The understanding was that everything had been vetted. It was all the same. So as an individual person, if you chose a colonoscopy, you had no idea that the one across the street was $1,000 less expensive and that provider had higher quality metrics. So that is not the world we live in today, right? The world we live in today, I think Castlight played a part of a role in terms of pushing cost to the forefront to individuals and quality to the forefront of individual people helping make decisions. And so, are we all the way there? Maybe not. A better position than where we started, for sure, from when we started the company. That was like an unknown to people to whom we were pitching the sales, both at the employer HR benefit level and then obviously the individual employees under them making decisions.
And do you think obviously healthcare is complex. You talked about systems, studying systems. You even talked about the system of your closed loop, CGM and
sure.
pump. Do you feel like the greatest instantiation of consumers using pricing transparency tools is in high deductible plans right now? Is that where we see it the most, where consumers actually shop for their care and think about price? Like where do we see this in the healthcare economy playing out today in your mind?
I do think the high deductible plans was the place that we were targeting when we were building Castlight. So the people that bore the biggest brunt of the economic delta. And I do think that, more and more healthcare is being consumed outside of health insurance. We're seeing the growth of lots of different services that are not covered under benefits.
Like a HIMSS, for instance.
That's right. Like a HIMSS, right? There's lots of I think about like the the quote unquote beauty and sexual components of health, right, that are not covered under health insurance. So I think people are starting to shop and starting to understand that. But I actually think that all along, the ability to access quality of your provider has been subpar.
Totally.
I get this question a lot, and we use, you're going to ask me about Glenn Tillman later. I get access to the Transcarent app. So like my friend's daughter is having a surgery done by the Kaiser. She's got this rare bone cyst. And so she said, is this a good provider? I instantaneously can look up and get all the information, reviews, and give like, feedback to her. And that world has changed and I think made a forward progression for individual
I totally
people.
agree with you. Like when those first generation transparency companies, Castlight was at the forefront, but there were others. I always thought the thing that I found missing at that time was, and maybe you guys did it, but I just always thought like price is one thing and it's really important, but like how you measure quality and the two combined together is like the holy grail in healthcare. And
sure, maybe
it's because it took CMS opening up their data sets right through the Blue Button or whatever in order to truly get real good quality data, but that strikes me as a big unlock for that space. So you were the CMO at Castlight, is that correct?
Correct.
And
I became chief medical officer after Dina Bravata. She was my mentor actually at the Stanford days when I was getting my master's, and so she enticed me to come to Castlight.
And so we have a lot of, and I want to talk about your journey because now you're co-founder, CEO, and you're president of Livongo. But let's start there. Doctors, we have doctors, lots of doctors who are listening to this podcast. Like Reena Pandey is a friend, and she made this great transition. It's actually helping CMOs, medical folks think about the corporate world, if you will. But like how do you navigate that transition as a doc to a startup? Like what was that like?
Well, I think for everybody, the initial transition is pretty jarring because you grow up, you spend 10 plus years in a very hierarchical system. That's very protocol driven and it's top down driven, right? The attending takes the risk on the individual patient and you're learning under them. So you don't do something that isn't under their purview. That is not the way startups work. There is much more, as you know, negotiation around solution finding. And I think a lot about the early days for me at Castlight. And I sat in the clinical content or the clinical team. We had a lot of interactions with the product people. I distinctly remember one conversation around a transesophageal echocardiogram that they wanted to call a throat probe. And I was like, you can't call that a throat probe. And they're like, but you can't call it a TTE. No one knows what that means. And that negotiation to get to what the outcome is that accurately represents healthcare and accurately represents individual people, consumers, accessing the healthcare. Lessons to make that transition. But I think the things that are real assets for physicians coming into the commercial world are all of us have seen, the real intricate parts of the system not working. And so it's hard for anybody trained in medicine to not on a daily basis think about the 10 to 20 to 100 ways that the system could be better because you live it. You live it on the provider side, not only in the patient, but on the provider. And so you have this real asset around understanding the broken pieces and then the solution around what will and what won't work. And I used to, when I was at Livongo, I met with a lot of people that were coming out of Google, Facebook, and they had incredibly brilliant people that were just going to come into healthcare and they're going to go tell that payer what to do. And, and you understand that can't actually work in the same mechanism. But their ideas could work in bits and pieces if you could deconstruct them and put them in a workflow that helped improve that workflow.
Question for you. We talk a lot about Bessemer. We look for what we call bilingual teams. And I think you and Amar, your co-founder at Homeard, are a perfect example of this. Someone who, a team that is both deeply empathetic and understanding of the healthcare, ecosystem, right, which is not an easy one. And then, but also, not just a team that is healthcare and used to all the old boy stuff in healthcare, but actually a younger Jenny who had been joining Castlight and was being integrated into a tech-driven organization. Like, what can a good tech-driven CEO do to make sure that they're, integrating the CMO or the medical person into the organization to get the best out of them?
Yeah, I think that maybe I'll actually use the example of what I did when I was at Livongo. So I had product, data science, engineering, marketing, and clinical strategy all reporting into me. So I put the leaders of every one of those organizations as equal peers. And so that's the solution had to come out with an agreed upon component to that, or they had to kind of present individual ideas, that old Hamilton scene where they actually tell me why I should do this or not do that. to try to argue, but those voices had to get into a room and argue. If they came out without arguing, we would have definitely gotten the wrong solution. And so I think it's giving equal voice to the different parts as a CEO. So like, are you sure you're actually deeply understanding or the clinical concepts are being represented? Doesn't mean they're right. Doesn't mean it's what we should do, right? But that they're being equally represented in a dialogue and creating a safe space for people to aggressively disagree to try to get to the right solution.
Awesome. Super great advice. Castlight goes public. You were part of the organization when it went public, if I remember correctly,
That's right?
That must have been a really amazing, experience. The first time you've
For
now
sure.
done it. You've now done it since. What made you take the call from Glenn and think about, taking the jump? Because you had a great role at a great,
Totally.
successful company. What was that? Walk me through that.
Yeah, and you know how life works, right? It was actually my good friend Daniela Perlroth, who is one of the highest IQ individuals that I know, who actually interviewed for the chief medical officer role at Livongo and called me and said, "Hey, Schneider, I think that this is a role for you." So I'm not looking for a job. She's like, "You just take the call." And so I met with Glenn, and it struck me that what they were trying to do was trying to change behavior for people living with chronic conditions through data. And I loved that, given my own personal experience.
Right.
And then I could see the way that they had structured their early go-to-market and their early revenue streams. And I could see the faults in that, having just come out of Castlight. And so I could see that I could add a lot of value into that ecosystem, both from a business growth and also from a product development
What's an
standpoint.
example of that? Just out of curiosity, because I did actually look at EOS Health, by the way. Speaking of Maria Health,
sure.
I looked at EOS Health before it was Livongo and sort of knew the early journey. That was a big miss for me. But what was one example of like the early, go to market that you thought, maybe we want to tweak a little bit?
Yeah, Glenn and the team came out of Allscripts, right? And so
Yep.
they had done a lot of their business selling into providers. And so there were a number of providers that were purchasing Livongo when I joined. And I thought, well, actually, our ability to drive the business revenue faster, the sales cycle is going to be much faster if we go into employers. And they had just had that idea. They had hired Jim Pursley as the chief commercial officer.
He's the best. Yep.
Yeah, Jim's, he's a dear friend, but they still hadn't yet gone into the benefits and the brokers and the PBs and kind of constructed those deals to accelerate the sales growth. And we had done that at Castlight. So coming out, there was a lot to add into that ecosystem. I think the second one early on is I distinctly remember it was day 3 and we were doing a deal with Target and I got asked the question, "Hey, you're chief medical officer. Can we hit these financial promises?" And I was like, I don't know. Does our product work? And they're like, "Well, we don't know. You tell us. You're the chief medical officer." I'm like, "I've been here all of 3 days." The answer was, "Could we not do the sales deal?" And the answer was like, "No, we have to do the sales deal." I was like, with confidence that we can hit those metrics, but what I have to do is back up and build an ecosystem such that I can understand the metrics. And so like this idea around having academic training and the rigor behind proof points and ROI and results, being results driven, was a clear thing coming out of Castlight and a very early investment for us at Livongo that actually changed our trajectory. Because not only did our price point deliver financial return on investment, but we could demonstrate and document with claims analysis the savings that we were giving to our employers. That was really critical at that time in the digital health journey.
I mean, what a rocket ship Livongo was, right? I'm curious, we talked about Gio. I'd love to talk about Gio and Glenn. What was your biggest takeaway from working for Glenn in terms of like, and ultimately now you're a CEO, founder CEO, like what's his superpower? What did you learn from him in that journey?
I think very highly of both Gio and Glenn, and I think Glenn has a tremendous number of superpowers. I think the ecosystem knows Glenn's a superpower, which is undeniable, which is sales and marketing. Mm-hmm. He's a brilliant sales and marketer. What I think people from the outside don't understand about Glenn is how he creates an incredible culture to drive people to be their best. It is really his secret sauce. He makes work fun. He's very mission-oriented. He is a servant leader. He allows people to excel and give them credit internally so that, we call it the fog, the friends of Glenn that follow him from company to company and come back around. He has an ecosystem because he trusts his employees. His employees really think highly of him, and it builds a culture. And that, I think, is, for me, the biggest takeaway lesson going into Homeward with Amar is how do we do that? Because that was critical for the success of Livongo. And there's not a Livongo with whom you meet that didn't love the journey, and they don't all love the journey because of the finances. Not everybody made the same amount of financial outcome. They love the journey at every step of the way because of the culture that we created.
That's really interesting. How do you think about the IPO of Livongo versus the IPO of Castlight? Not necessarily financially. I mean, just like from a market perspective in that, I don't know, Castlight peaked at $4 billion or something like that. And then, fell down. That happens. And then Livongo was just like, I mean, busted through all parameters that anybody thought was realistic, right? Like, how did you, given that you both went through both companies have good leaders, both companies have good products that were timely at, in the moment, and yet one was so different of an outcome than the other. Like, how do you intellectually or cognitively, like in retrospect, think about that?
I think about it under maybe two different ways, some of which we controlled and some of which we didn't control. And so I think timing is important in the building of all these businesses, and hitting the timing where with market sentiment, I think is a skill as much as it is luck. I think it's a combination.
Mm-hmm.
I think Livongo hit that in an ideal spot. I think that Livongo did a great job of demonstrating outcomes and publishing and showing results vision. And I think that at Castlight, our vision was bigger than our body of results at the time that we pushed the company forward. And so I think we had a little bit of a stronger, more sturdy base underneath the vision at Livongo. Both cases were, I think, right timing at the right place and benefited from the macroeconomics.
It's really interesting because I always say, like, people ask me on panels, I'm sure you're on a lot of panels, like, what's the one thing you look for? And it's like, I think outcomes set you free in healthcare, and so focusing on ROI and clinical outcomes,
for sure.
both financial and it's like, but it amazes me still to this day how many decks I see, because I care deeply about healthcare like you, that don't talk about outcomes. And even in the early stage, you might not have the outcomes, but at least just show me the path of how you're going to get there.
Totally.
And so I think that focus is so critical, so critical. So you're at Livongo. Is it an $18 billion company at the peak? Something like that. Is that right? And you were there were you there for the acquisition by Teladoc?
I was. I joined in 2015, as chief medical officer, became president in 2017, helped take the company public and stayed through the acquisition. But when the acquisition closed, I joined General Catalyst as an executive in residence.
Okay. So you decided you weren't going to, I'm sure many people probably wanted you to stay and be CEO, but you decided it was time to do something different.
I did. And again, from my vantage point, the combination of the two businesses was exactly the right combination for the people we were serving. So this combination of digital health, but also wrapping in tighter services and being able to do additional augmentation around prescribing power. There's no question that the combination of the two businesses was the right combination. And it was very clear that the Teladoc team wanted to kind of take and run with that. And they let all four of us officers in operating positions leave the business, which is a little unprecedented, but that was the path and choice.
Yeah. So you go to GC. Did you go there with like an idea that you wanted to start a company, or was it, hey, hang out, kind of understand what the market's like, see what the VC game is like, and
It was initially a little bit more of the latter. I wanted to take a breather. I'd been so deep in Livongo and just kind of lift my head up, look around the ecosystem. And Homeard will tell you within 1 or 2 months, he's like, you need to go operate something. I'm like, I need to go operate something. It's like you know this. You know who you are, and I know who I am, and I'm an operator. I love the check boxes. I love having my feet held to the fire, the good and the bad. I love building teams. And so then I spent some time circling around which ideas to pursue. And I do that with Amar. Amar and I are great work partners. Yeah. He is the best. Yeah. And we were at Livongo. And even while he was at Teladoc, we were starting to circle on some ideas and chase down a handful of them. And we're most excited about Homeard.
Yeah, I remember I'm on a board with him, and he called me a couple of your ideas. But then, it was very clear Homeard was the one. Well, tell our listeners about Homeard for those who don't know it. What you guys do? Yeah,
Homeard is a native AI platform focused exclusively in healthcare delivery in rural parts of America. And so our business model, what we do is we enter and we own the risk on Medicare Advantage. I think earlier you said Medicaid, but we're actually Medicare Advantage and dual eligible individuals in rural counties. We have 100,000 members under management today, predominantly in Michigan, which has the third largest number of Medicare Advantage members living in a rural part of their state. So we partner with the different insurance companies. We manage the risk and the outcomes on those populations in rural counties.
And you said AI native, I'd love to understand that a little more, but is it all virtual care? How do you
It's
guys
not.
deliver?
It's a hybrid care. I think one of the biggest lessons that we have, both Amar and myself, coming out of the Livongo teledoc solution is Jason Gorvick did not solve healthcare delivery in rural parts of America with a virtual-only solution. There is a true dependence and necessity for having technology as a leverage point in a world where resources are very scarce, and that is true in all of rural America. And then the ability to actually translate that and scale that is dependent on trust factor, which is really hard to come by in rural parts of America, different than in urban. And so we do technology with a wrap of services. So the way our model works is we take on whole populations. We partner with the existing health systems in the ecosystem to share in some economics and that population for certain actions. But we profile the population and the highest risk, those at highest risk for poor outcomes. We also bring our own care providers into those people. So that's APPs, it's community health workers, it's medical assistants, it's MDs. And we do that. We do that through in-home almost always. Our first visit is in-home, and then we establish virtual follow-up for those very high-risk population patients. So the bulk of our visits over time are actually virtual, but we make a big upfront investment, which gains us the ability to continue to do the virtual care in those communities.
So I'm going to posit something, but I'd love you to walk me through the math. Like you said, you're dual eligibles and Medicare Advantage members mostly.
Right.
Is that correct?
That's right. Exclusively.
Okay. And so is the goal to really decrease MLR it might be 5 now and you're trying to get it to, 85 or whatever? Or is it really that these folks are at like 120 and you're trying to get it to 110? Like, how does the math work? Because you're taking risk. And so I'm trying to I'd love you to walk through like an example of a typical sort of member and how you're thinking about managing that cost, as well as obviously the quality of care. The two are linked.
Yeah. So what I would say, maybe where I'll start, is that healthcare outcomes in rural parts of America are much worse than they are in urban. Yeah. So overall mortality is 23% higher. The people, and this is my family. So as I say this is like where I grew up, back to our original part of the conversation. Right. People in rural parts of America are lower socioeconomic, lower health literacy, and lower education. They have higher rates of chronic condition, higher rates of mental health and substance abuse disorder. So it's a very different population. When you look at the Medicare Advantage population, these MLR targets are far higher than the urban counterparts when you carve them out from the health system. At the payer level. And so we have populations that are in high 90s, and we have populations that are in high 80s. So there's some variance most of the variance is dependent on, is there a healthcare facility within your proximity? And as rural healthcare and hospitals continue to close, that means that the population's health is worsening, right? And when we go meet those individuals, those people are often living with undiagnosed chronic conditions. We have these stories of people who are farmers driving tractors who've had, they have wild congestive heart failure with an ejection fraction of like 10%. And in the history, they'll tell you about the time their left arm was really sore, but they were in the tractor and they couldn't go see a doctor and there was no place to go. So they just kept driving the tractor until they got home and then laid in bed for a day or so and then got up. So in my medical mind, I'm thinking, oh, this person had an acute MI. They've lost a bunch of their heart tissue, which is why they have congestive heart failure and their heart, functions at a fraction of a normal heart. But the individual never sought care or attention. So there is a lot to do in terms of what are the necessary care pathways to deliver to these people. And then there's a lot to do in managing the intensive and excessive kind of medical components.
What are some of the results that you guys have seen? You've been you've been commercial now for 2 years, 3 years, something like that. Is that right, in market?
Yes, that's right. Yep, that's right. We've had patient population under management for 2 years, starting in 2024 and 2025. And so we've seen incredible rates of engagement relative to what we're offering. People love it. And that's frankly like a fairly low bar. Like there is no healthcare provider. They like a healthcare provider, right? So I joke like we're better than nothing, which is a good first step. And we're seeing, if you look at ER utilization rates, we're seeing decreased ER utilization rates. If you're looking at medical compliance in terms of longitudinal care for chronic conditions and the refill prescriptions, we've radically increased that. If you look at appropriate utilization in inpatient and decreasing inpatient and transitions of care out of the hospital when people end up at the hospital, the big healthcare drivers, if you will, we see improvement in each of those categories. And that drives both the total cost of care, which we're responsible for at a population level, and it also, in our ability to get in and see these individuals, we're documenting their needs, and it also increases the total revenue. So it's both an increased total revenue and a decreased total cost of care. And the reason that value-based care in rural markets works is value-based care in general, I think version 1.0 was fairly capital expensive.
Yeah.
Right? With results that are very long and take a long time to prove.
Not a great cash flow business. Yes.
It's not a great cash flow business. I think that's right. And in a macroeconomic environment that these are done predominantly in Medicare Advantage and some in Medicaid in a highly regulated, and we're watching kind of lots of big changes happening out of the federal government. The difference is that the ability to leverage these technology tools where you're stripping out tons of inefficiencies to allow these health systems and hospital systems that are operating in a razor thin margin to be able to deliver more care, the same amount of care to more people, there's a really big leverage point. The population that's in existence doesn't have a lot of options to go to other places. So it's a really great place to sit in this next round of value-based care.
I was gonna say, I mean, you're from Winona, so some of these policies that are being, formulated at the national government in terms of Medicaid cuts. We don't need to talk about V28 and Medicare Advantage, but that poses a whole separate challenge. But just Medicaid, I mean, this is going to destroy further the ecosystem, as you started talking about it at the beginning of providers and what have you in rural America. In some ways, that's tragic. I mean, it's obviously tragic for those communities and I think for our country, but it actually really presents an opportunity for you guys at Homeard.
Totally.
I wonder how do you think about that it's great as a leader. It's probably horrible as a human. So I'm curious, how you're navigating the business through these challenging times.
Yeah, and I listened. You had a podcast, and I'm blanking on the gentleman, the policy gentleman that talked about.
Joe from Marwood Group. Yes,
the Marwood Group. Yeah, that's right. So you're right. I think that the Medicaid cuts disproportionately, as was discussed earlier in that episode, the Medicaid cuts disproportionately hit rural because there's a higher percentage of people on Medicaid living in rural markets.
Right.
And the margins of hospital systems in rural are much lower than the margins of hospital systems in urban. So a little ding is a huge ding if you're in the rural part of the market. But what I would say is that the ecosystem in rural markets also hasn't been functioning. It's not like we took a highly functioning system, we tweaked one policy rule, and now they're going to fall out. Actually, the ecosystem has not been functioning. We have been in that ecosystem for years thinking through how do we partner? What are the assets and tools that we can bring into health systems such as RCM? They leave many of the hospitals, the $20 to $200 million hospitals are leaving 30% of their claims on the floor because they're still stuck with the person down the street operating, their claims billing cycle, which they had to get under meaningful use. They qualify, but it's not optimal. That's very real in our markets, right? And so there is an opportunity here to actually completely transform and leapfrog. You've, I think, heard me say this before. I really liken it to rural health is the third world part of our first world country. And if you think about the innovations, I was in Rwanda with my kids 2 years ago, and you go to a market and people are bringing in flour on the back of a donkey, and then they're paying for it with their cell phone. I can't use my I live in St. Helena in the Napa Valley. I can't use my cell phone to pay for anything at my farmer's market. Like, I actually have to have physical cash. The reason I say that is there's these technological advances because they kind of were hit rock bottom. In many ways, that is an opportunity for us in rural healthcare. And I think a lot about the train was already going to the brick wall. These Medicaid cuts is making the train go faster. There's the rural health transformation $50 billion allotment. That's not enough to do it. But if you can be smart, you can take advantage of that. And either you have to take the actions that is going to hopefully encourage people to take at a different adoption rate to turn the tide. So we think a lot about our solution into the ecosystem is not just what does Homeward bring with the payers to manage the population. We partner in the ecosystem. We partner with health systems. We think about their billing cycle. We think about augmenting their specialists. We partner with local grocery stores, Meijer in the state of Michigan, for example, because that's where everybody goes. That's an outreach. That's a pharmacy for us. And it is an ecosystem turning point and leveraging these assets in an area of the world, Steve, where almost no startup company calls in rural markets with their solution. They are really, truly left behind, and they're the ones that frankly need it the most. So there is an incredible opportunity, but it will become more painful before it becomes successful in the communities. Of that, I'm convinced.
Yeah, I listened to a podcast of a friend and your co-founder, Amar, and he made an interesting point, which I hadn't really thought about, is that there's also less tech debt in these areas because they haven't had to buy all these crappy healthcare IT systems that the rest of the world, the rest of the U.S. system is laden with. Where, maybe there's just more of a blank sheet of paper for you guys to innovate on, which might be an opportunity too. So I thought that was a really good point. Hey, we talked earlier about some great founders, CEOs that you worked with, Gio and Glenn. You talked about some of their superpowers. I'm curious, what do you think I always ask this of every entrepreneur that I meet, what do you think your superpower is as a leader?
I think probably two things. Is one, because I've been on the healthcare delivery side and I'm a chronic patient, I think I'm fairly empathetic to the what, and I'm very direct. And so I don't beat around. My family tells me I am the only person out of Minnesota who doesn't speak Minnesota nice.
You're not Minnesota nice?
I'm not Minnesota nice. But I think that's really helpful when your job is to clarify direction for teams and move things out of the way.
Yeah, I love that. And then final question. You've had an illustrious career, as Google said when I Googled you.
I like Google. Google is my friend, like you said.
Lots of entrepreneurs listen to this podcast, and I'm sure would love to grow up to be you. What would be your take it all in and it's hard to do, package all together. What would be if someone said to you, Jenny, as an entrepreneur, what's your one piece of advice to me? What would that be?
For me, it's always the same, which is, and I say this to my kids pretty much every day, which is bet on yourself. At the end of the day, you know yourself, and make the biggest bet. You are the thing that you can most control. And so have confidence in yourself and double down on yourself.
Love that. Well, Dr. Jenny Schneider, thank you so much for coming on the podcast. Thank you for what you guys are doing at Homeward. It's really important for our world. So I really appreciate it and appreciate all you've done for our industry. That honestly I benefit from some of the work that you guys have done to pioneer the space. It feels like it's finally taken off. So let's hope for brighter days ahead.
Let's hope for it. Yeah, and thank you to you for the opportunity to be here, but also for doing the podcast. As I shared with you earlier, I'm an avid listener, so really appreciate it.
I'm glad you have to listen to my voice while you're running, 26 miles in your next marathon. So good luck with those. All right, thank you so much, Jenny. It was really a lot of fun. Bye.
Bye.